This is the EMS Research vlog and podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Welcome to the EMS Research vlog and podcast from the studio here in Houston, Texas. I want to start out by drawing your attention to our website, where you can check out anything that's show related when you go to professorbram.com. That's professorbram.com. At the website, you can find the latest show, see my talks in the media, order the latest book, and also look at how to participate in research. This is all stuff that can help you grow in the world of EMS research. Like right now, I have a research study open for first responders. So if you don't mind being interviewed by me, then go to my website at professorbram.com and click on the current research tab to apply. I want to tell you about an article that just came out in the New England Journal of Medicine called Intensive Ambulance Delivered Blood Pressure Reduction in Hyperacute Stroke. You know, the authors looked at how medical emergencies like a stroke, it can be tough to decide on the best treatment, like especially right away, because there are two main kinds of stroke we all know about: ischemic strokes and hemorrhagic strokes. But their study looked at whether lowering the blood pressure very early on, especially like right when the patient's still in the ambulance, to think, gosh, is that something that could help improve recovery for stroke patients? So the researchers worked with over 2,400 stroke patients in China, and these patients had high blood pressure and were experiencing movement problems due to a suspected stroke, right? And so they were divided into two groups. One received immediate treatment to lower their blood pressure, while the other group received standard care without the immediate intervention. And after 90 days, the study checked to see how well the patients were doing in terms of their ability to function normally. And they found no overall difference between the two groups in terms of recovery. But when they looked closer, they noticed that early blood pressure control helped those with hemorrhagic strokes, right? So those folks that were bleeding in the brain had some positive effects, but at the same time, it seemed to have a negative effect on those who had a clot ischemic stroke. And so what they found was that trying to lower blood pressure right away in the ambulance didn't make a difference for all the stroke patients combined, but it could potentially help those with bleeding strokes, and it might not be ideal for those who have the blockage kinds of strokes. Now, this information is obviously important for making treatment decisions in emergency situations. So after all this came out, I read an article by the famous paramedic Mic Gunderson and Dr. David Rose, who responded to this research study by writing an article in the International Journal of Paramedicine. And the article that they had was, it was a title called "Not Too High and Not Too Low, the Goldilocks Approach to Prehospital Treatment of Severe Hypertension with Stroke." The authors were both get to be here with us today. And so I want to be able to have them tell us more about themselves in a sort of an extended fashion, and also help us get into the topic of how dealing with high blood pressure in the field, might look or should look for EMS. So first of all, I just want to give both of you guys a chance to do your long introduction. So Dr. David Rose, do you want to go first?
Sure. Thanks for having us, Bram. It's a pleasure to be here. I am a strokeologist, if you will. I'm a stroke neurologist. I trained at the University of Pennsylvania in a stroke fellowship in Philadelphia. Before that, I was at the University of Miami to train in general neurology residency. And before that, I was at the Cleveland Clinic for internal medicine. And so my areas of interest for research include pre-hospital blood pressure lowering, as we're talking about today, which is, guess why I'm invited. But also other things like atrial fibrillation, AI detection, and in stroke, and also hemorrhagic stroke. How do we reverse these folks who are on anticoagulation for their AFib? There's a lot that goes on in the hospital with stroke that we still don't really fully understand how to best treat from a logistical standpoint. And then the pre-hospital area, which is what we're going to be focusing on today, of course, really is like the holy grail of, if we can get these things fixed even before the patient arrives to the hospital, that's one of the best areas to really focus if we can and get the patient all teed up. As far as myself, I teach at the medical school at the University of South Florida, Go Bulls, here in Tampa, Florida. I'm also on the staff at the Tampa General Hospital. It's a big 1,008-bed facility here in beautiful, sunny Tampa, Florida. We have a 32-bed neuro ICU. We see about 1,500 stroke patients a year. So we're quite a busy service. We have 5 stroke docs, 3 neurointerventional, neurosurgical, 4 stroke docs, and a whole bevy of neurocritical care docs. So we're quite a busy service. I also love to teach. I wrote a book called Laughing Your Way to Passing the Neurology Boards for the residents. And so it's a pleasure to be with you today.
Oh my gosh, that is such a great introduction. Nothing's getting edited out of that. So that was really great. So Mick Gunderson, tell us about yourself next.
Yeah, so I've been in EMS since 1975, coming up on my 50th anniversary in EMS in a couple months. And I started out as a military medic in the Army as a 91 Bravo, and then transitioned into civilian EMS. And this was still in the 70s before Florida, where I was living and working at the University of South Florida Medical School in an oxygen transport physiology, but before Dr. Rose was there. They hadn't passed paramedic legislation yet in Florida, so I was in the first group of paramedics certified in the state of Florida, and one of the first ACLS classes and stuff. So I had the wonderful opportunity to kind of be there when a lot of this stuff all kind of got started. And but as I mentioned, while I was on my days off from the ambulance, I worked at the medical school, got very interested in academic medicine, and actually ended up starting one of the first peer-reviewed journals for EMS called the Tampa Bay EMS Journal, and started publishing that on this new computer that had come out called a Macintosh that could do desktop publishing. And we published that for about a year. It became the Journal of Prehospital Medicine, went national, and then that journal merged with the efforts of a new group that was starting called the National Association of EMS Physicians. They were interested in starting a peer-reviewed journal, but there were 2 gentlemen from the World Association for Disaster Emergency Medicine that had already started a journal. Peter Saffer, who many people may recognize his name as kind of the father of a lot of resuscitation research, developed mouth-to-mouth for breathing and combined that with the chest compressions for what we now do as CPR and a lot of brain resuscitation research, et cetera. And then the other guy that was his co-editor was R. Adams Cowley, the guy who started shock trauma in Maryland. So we all got together, put together one journal, and it became Pre-Hospital and Disaster Medicine, which is still in print today. But I started drifting away from research and started really getting more into the then nascent field of quality improvement for EMS, which we now use a term called improvement science, which is more reflective of how I got into it. I was trying to take the skill set that I learned in research and apply it to daily operations in EMS. So that's been my kind of professional focus for throughout my career. And what kind of led to this particular project was trying to improve the process of care for stroke. Now, along the way, after I stopped working out in the field, had a number of different quality improvement jobs with Office of the Medical Director. For a while, was the National Director of Clinical Systems for the American Heart Association, and had stewardship of the Mission Lifeline program and expanded that from STEMI into stroke and resuscitation. Was an EMS system director for a while, and now I primarily do consulting and teaching and quality management. But one of the activities that I got engaged with was doing some regional stroke conferences, and that's how I met Dr. Rose. Is he came in as an invited speaker to talk about blood pressure control, and his presentation led to some conversations about why aren't we dropping the blood pressure out in the field. And so that kind of led to this paper.
Well, so that is the question. Dr. Rose, why aren't we? What's going on here?
Well, you mentioned the Interact 4 study, which is how we based our paper hypotheses. And I think it's a case of throwing the baby out with the bathwater. You have two flavors of stroke, if you will, chocolate and vanilla. No, I mean, ischemic and hemorrhagic, right? And so if you lower, as we've seen with Interact 4, the pressure for undifferentiated stroke, in other words, before we have a CAT scan showing whether it's ischemic or hemorrhagic, then it turns out it looks like it doesn't make a difference, as you rightly pointed out. But getting into the weeds, more granularity of this phenomenon, you see there actually is a significant separation. It benefits the hemorrhagic strokes a lot, 30+%, but it may harm the ischemic strokes a lot, 30-something%. So, how do we separate them out? Or is there, like Mick and I pointed out, a Goldilocks approach where we can kind of tease the needle, thread the needle, and just tease out the exact pressure that we need that's not too high and not too low? So I feel like, articles like this, Interact 4 study, have kind of made a lot of folks in the pre-hospital setting a little bit hesitant to use antihypertensives before the patient arrives to the hospital with a stroke. And so, unless you have one of those ambulances with the CT in it, which are very expensive and rare, then you really can't necessarily make that determination whether it's ischemic or hemorrhagic right there. You really just don't know. And that's why, as you know, we don't advocate for aspirin, for acute stroke symptoms. A lot of people think, oh, someone has an acute stroke, let's go ahead and give them a couple aspirin before they get to the hospital. No, that's inappropriate, right? Because it could be 20% of all cases in the US, between 15 and 20% are hemorrhagic. So it can make things worse. So I think that's the reason. People are a little bit hesitant seeing this data. At the best, it doesn't help. At the worst, it could harm, But again, teasing it out, there may be a subtle way to do this that actually we can, help everybody.
Well, because it sounds like there's small leaps forward happening. And I see that you're kind of cautioning against the overreacting to the research findings from China, right? Because if you reduce the blood pressure too much, you could hurt somebody with existing artery issues.
Right.
And so we're looking at maintaining the status quo. Is that what the current best plan should be? Because I'm trying to be aggressive here. Like, how do we? I want to fix everybody.
Well, let me frame it up this way. So the thing that struck me when I heard Dr. Rose's presentation the first time on that stroke lecture he gave at the conference I was sponsoring is he really highlighted the fact that patients with very high blood pressures, still undifferentiated coming into the emergency department, are going to need to get their pressure lowered to meet the guidelines that have been established by American Heart, American Stroke Association, European Stroke Organization, et cetera. And those guidelines say very clearly that you shouldn't give the thrombolytics to patients if their systolic pressure is greater than 185 or their diastolic is greater than 110. And so the point that Dr. Rose made in the lecture was that we need to lower this, and what's the best way to do that once they get in the ER. And so I'm listening to this and saying, well, why are we waiting to get into the ER? If I know out in the field that, we call the stroke alert on this patient, we can measure their blood pressure, we can give drugs out in the field. So why wouldn't we give one of these antihypertensive drugs out in the field so that by the time we got to the emergency department, the blood pressure problem is resolved and we could go, straight into treatment if necessary after they got their CT scan or other imaging studies. So it was a time savings, much like the same scenario we faced years ago with why do we wait until we get to the ER to get the 12 lead if we could get the 12 lead in the field and just kind of save that time. So looking at this through my quality improvement lens, I thought this is ripe for a process design change. Let's change the design of the process to prevent an unnecessary delay by initiating the treatment out in the field rather than waiting to get into the emergency department. And
yeah,
then
because we have all the way from clonidine PO to labetalol IV, right? We have a large range of things to like that we might be able to work with, but it's like, it's just beyond me why, and I do not understand it, but it's beyond me. Why don't we have another way to figure out if this is a hemorrhagic versus ischemic stroke? It seems to me that by now we would have some kind of blood test, like we have a D-dimer to see about PE. Why can't we have, some kind of something special? Because it sounds like if we would know in the field right away, then it could potentially help treatment.
Yeah, they're working on that. I will say there are a lot of folks out there that are researching this as we speak. I have some colleagues in Australia who are working very, very closely with it. It may be years before something like that comes out. And otherwise, these big ambulances with the CAT scan in them, they cost like $1 million a year just to maintain, $1 million to buy in the first place.
Yeah.
And my colleagues are saying they're down 3 months of the year. You hit a pothole on the way to the hospital and the CAT scan's done. So you got to get it fixed. And it's, when it works great. And then they can go ahead and decide, if it's ischemic or hemorrhagic, maybe even consider lytics in the field, which is awesome. But the number of folks that get that is few and far between, unfortunately, for the folks that tell us how it's going. That's the report on the ground. This, no pun intended, from the folks in the EMS ambulances that have the CAT scans. But
well, I don't want to pull too much attention away from the article, but the thought that I have as a paramedic who works every day, in the field right now, I'm thinking to myself, the perspective I have from where I stand is that it seems like that the system that's in place is really set up by these guidelines, right? Like we have the golden hour and these kinds of things, and the hospital cares about those because meeting that criteria means that the accreditation can continue and the continuous, all that stuff happens. But my view of this is that there's some also bit of attitude thing that goes on with this, because it's sort of like the attitude of, well, we're within the hour, so we're okay, or we're within the, so the can you comment maybe on the legitimate lack of rush? Because we and maybe you don't see it like I do, but I sort of think that there's a tendency, if you have a trauma patient, to treat that like a rush case, because the bottom line is that person's got to get to surgery right now. Well, we don't do that, honestly, Dr. Rose. We don't do that with y'all. We're just like, okay, I know it's an emergency, and then when we get there, we're like, okay, we're still in the criteria, and there is no, but so should we maybe be looking at it from that perspective?
Absolutely.
Gosh, there is no, the legitimate rush is, because we're trying to rush to figure out about TPA or not, and by running a scanner in the field. What about just like, hey, get your butts in gear, and that time sensitive element get reinforced? I don't know. That's
we know that a person will lose 1.9 million neurons every minute. An ischemic stroke goes untreated without TPA, for example, or TNK now. And multiply that times, 60 minutes in an hour, it's 120 million neurons an hour that someone will lose. And that actually can translate into accelerated aging. So someone can actually lose weeks and months of their life just because, we're just not taking it as seriously and as quickly as we do for trauma or MIs or heart attacks and so forth. But every minute counts. I mean, every neuron counts. I don't know about you, but I can't even spare one neuron. So
heck yeah. So do folks like you need to start being mean to EMS professionals, ER doctors, and say, look, get your butt in gear?
Well, you win more bees with honey, right? I would say we have to figure out a way, firstly, to show data that this actually works. Everybody knows that we're under the radar and under the microscope with respect to the door to needle times, as Mick pointed out. The needle keeps moving, and American Heart, American Stroke Association, to their credit, have been really pushing all of us, once a patient arrives to the hospital, to get TPA and TNK for the ischemic strokes into the patient 50% of the time within 30 minutes, 75% of the time within 45 minutes, and 85% of the time within an hour. And if we fall out of those numbers, and sometimes it's kind of close, every month we have to analyze and send this data in something called Get With The Guidelines. Yeah, and if we fall out, then yes, you're right. Hospitals can lose their accreditation. So it's really important to get these folks. And I will say, for the most part, the ER team is very quick with alacrity, getting these folks, teed up with the CAT scans immediately. This quick stroke scale score, vitals are all set so that the labs are drawn quickly, and EKG's there, X-ray. So everything's done very quickly, and we can really assess whether it's a TPA or TNK candidate. As far as the hemorrhagic strokes, however, it's kind of like the forgotten, stepchild for a while. It's really been all the research focusing on ischemic stroke for the past 15, 20 years. Just now, we're realizing that, for hemorrhagic stroke, we have to be just as quick, because time is brain for that too. But what do? We don't give those folks lytics. Well, what we do is we lower the blood pressure, right? Because that'll prevent hematoma expansion in the brain, which will kill a person, right? So it's not the hematoma itself that can lead to a fatal herniation syndrome, where the brain squeezes out of the back of the skull, the foramen magnum, the largest hole in the skull, like toothpaste, and the medulla oblongata gets destroyed, and that's where the respiratory centers are. So the brain basically tells the lungs to stop breathing. That's how someone dies from a hemorrhagic stroke. It's the expansion of the stroke, and persistently elevated blood pressure does that. And that's why you saw in Interact 4 such a positive result for the hemorrhagic stroke patients, because they brought the pressure way down, and these folks did 30% better, right? So is there a way, back to the initial question, that we can kind of thread that needle? I think we can all agree, and I'd love to hear Mick's thought on this too, that nothing good happens at some of these highest pressures, right? 220s, 250s, 270s. I had a guy just yesterday, 289 over 187. I mean, nothing good is going to happen at that number, right? We can lower that guy, whether it's ischemic or hemorrhagic. It's undifferentiated, sure. But, either way, whether we lower it down, 50 or 100, I think either way, we're going to improve an outcome, because that type of number is going to be extremely bad. The question is, can we do that in an organized, logical way pre-hospital? And that's where, Mick's expertise really comes in here for this type of organization strategy.
Yeah, and the thing I want to emphasize, though, Bram, is keep in mind that those American Heart, American Stroke Association guidelines are something that the hospitals follow, right? They pay a lot of attention to that. So if we have a patient out in the field with a blood pressure above those thresholds, 185 systolic, 110 diastolic, they're going to get their blood pressure lowered before they get lytics if they're within that 4.5 hours for eligibility for thrombolytics, and the much longer time frame for thrombectomy. But the difference between what we're talking about and what they were doing with the Interact 4 trial is the Interact 4 trial was trying to find what's the optimal blood pressure to have a stroke patient at during their acute phase of care. And I looked at this very differently, and Dr. Rose, shares this perspective with me. I just want to get them just low enough to be eligible to get the thrombolytics.
Right.
So it takes the question off the table about whether or not, harm is caused, because we're going to be dropping this blood pressure to below 185 systolic, regardless if they're eligible for lytics. The only thing that we're suggesting with that paper that we published, and I should mention that is an editorial. We're not presenting new data. We're simply interpreting our take on that INTERVACT 4 paper that was published in the New England Journal.
Yeah.
We're advocating that we take advantage of the time we have in the field, if we have the equipment and resources available to drop the blood pressure, to do so in the field, since they're going to get it dropped anyway. So why not do it sooner than later and save the time? But the other thing that came up during Dr. Rose's presentation that really caught my attention was he was talking about a drug called clofidipine. And the thing that impressed me about his description of clofidipine was that it acts very quickly. And if you stop it, it burns off really quick. So as a paramedic, I'm thinking, well, if I did get in any trouble or the patient had any sort of problems with it, it's great to use out in the field, because, I can just taper it off or turn it off and it'll just go back to baseline. So that's one of the things I really look for in a drug to use out in the field, is if the patient has a bad reaction, do I have an antagonist for it, or is there something I can do to get us out of trouble in our, limited resource environment in the back of the ambulance?
Yeah, because wiping the nitro paste off may not be enough.
Yeah, because it's in there.
Who wants to wipe it on in the first place? Who measures drugs in inches anymore, really?
So the only, kind of issue I had with the clofidipine, though, is it needs an infusion pump. But more and more ambulances are carrying infusion pumps, so that there's more flexibility for frontline ALS units to do interfacility transfers. Whole blood is really catching a lot of traction. So there's going to be a lot of potential use for infusion pumps out in the field. And this clofidipine is so concentrated, it's not going to be practical to try to control it with a microdrip chamber like, you could with dopamine or something. It's very, very small amounts of liquid that come out for those infusions, which is an advantage because it doesn't, cause a lot of volume load on these patients.
Nice.
But it necessitates having to have that infusion pump in the field. So that also struck me as something that made it much more feasible to do this out in the field versus, some of the other drugs that they might use in the emergency department.
Well, and you said something about, whole blood related to that. I just want to say that when I administer whole blood, I definitely prefer to do it without a pump if I can, because, when you're moving at all, blood bubbles can just really, because of the thickness of the blood. So I try not to have to use a pump when possible for blood. But, I would say there's a pretty good percentage of ambulance services that do have pumps because, from my history, there's a lot of places out there that don't just do 911, like a lot of private EMS out there takes care of 911 and transfer. And so by default, they have that, or they're really familiar with it. So also don't think pumps are that expensive anymore, compared to what they used to be, unless you have a networked one with the whole big system, which is not necessary, so that's why this is all so exciting to me.
Yeah, a Sapphire pump, which is a pretty popular one used out in the field. I think the street price is like $1,500 or $1,600. So it's not, a new defibrillator sort of magnitude of investment. So again, I think that makes it a lot more feasible. And, whether you use it for blood or not, the broader point is there's a lot of potential uses for the pump. It wouldn't be just for dropping blood pressure out in the field. And so combining those two factors, that there is a drug, this clofidipine, that has a very nice profile for use out in the field, but it needs a pump. Pumps are becoming more popular. It just seemed to make a lot of sense. All that being said, when we published the editorial, one of the things you have to do when you publish is have a disclosure statement to make it clear to the readers if there are potential conflicts of interest that may, influence the content of the paper. And for full disclosure, I wanted to make two things clear. One is I'm the editor-in-chief of the International Journal of Paramedicine. But editorials are not typically peer-reviewed, but out of an abundance of caution and to maintain as much propriety as possible, I went ahead and sent the paper to several editors to do peer review on it anyway. And so I wanted to make that point. But Dr. Rose and I are working on a project to actually start using clofidipine out in the field. And we're going to be doing this with a single ambulance service. And they will have their infusion pumps, and we're approaching this as a simple protocol change because the medical director there thought this made a lot of sense. Let's go ahead and do it. They actually had labetalol already in their protocols for some other indications, so this wasn't a completely off the wall idea for that particular system. And so they're going to make the protocol change. And so again, looking at this through the lens of a quality improvement project, we're using an already FDA-approved drug for its, indications, something that's consistent with the guidelines from the American Heart, American Stroke Association. So there's no new science per se that's going to be introduced here. And that's why we approach this really as a quality improvement study, where we're just changing the sequence of the process steps. So rather than waiting until we get to the emergency department to initiate the lowering of blood pressure, we're simply shifting that same procedure, the same drug, but we'll give it out in the field instead to for the improvement of removing that preventable delay. So instead of having to get to the ER, then wait for the blood pressure to be lowered before we could give the lytic or proceed into the thrombectomy lab, we'll initiate that out in the field. And so,
and with different thresholds, I might add. So we don't want to redo the INTERACT 4 trial, but we did want to say, just bring it down to below where we need to get the cutoff for the thrombolytic eligibility profile. Less than 185 systolic, 110 diastolic, not 150s, and certainly not 130s, which was the goal in the INTERACT 4. And that could be why the hemorrhagics did so great and the ischemics did not do so great, because that pressure was way too low. And maybe they started, even too low. I would say we would only include patients whose pressure were over 185 over 110. Everyone else, let them just ride whatever they're at. If they're at 159, you stay at 159. When you need to bring that down any further, until, a CT shows hemorrhagic stroke, then go ahead and lower it to 140 or 130. But if it's ischemic stroke, you're right on the money. You can go ahead and give the lytic at that point.
And I tell you, that's paramedics. That's great news to paramedics ears, because I tell you, we want to do something, right? We want to do something to be helpful in the moment, and that's like one of the things that we shine at. So it's great to hear that this is, a possibility.
Right, and as Mick had mentioned, we finally have a great drug that we can actually get out of trouble with if there is overshoot. So the main concern everyone knows is hypotension, right? You give an antihypertensive, especially when it's so strong as clofidipine. It's an IV calcium channel blocker. It's a dihydropyridine calcium channel blocker. It's strong. And you just need, it's a low volume infusion too, just a couple of drops, and you're starting to drop the pressure pretty quickly. It has a 1 minute half-life. So because it has such a quick onset, it also, as Mick pointed out, has an amazingly quick offset. Full recovery of blood pressure can occur in just a few minutes. Full recovery. So, if you do run into a situation where there is some overshoot and some hypotension, turn it off or even turn it down. All the trials that have been done on this medication really have shown that, it does occur. Hypotension can occur. It's not that common, but it can occur. And it totally rebounded once you turned it off. You don't even need to turn it off. You could even turn it down and it'll come back up nicely. So that's the beauty of it. You can really tailor it because of that quick half-life. And we even joke, if you want, 159 and a half systolic, you can get it there because it's so titratable.
And so you're talking about small quantities. Are you thinking that we need like a pediatric infusion pump? Is that the kind of small quantity we're talking about?
No, the standard
Okay.
infusion pump is fine. It's just too small of an infusion to control manually with the micro drip chamber because
Gotcha.
the volumes are too small. Like trying to regulate 2 drips per minute versus 3 drips per minute is
Right.
just not practical. Plus, you have the vibration factor where you get a premature shearing of the micro drop. So we need more precision with
Hmm.
use of this particular medication.
Okay, so I've never heard about micro shearing of the drop, but that sounds like it makes sense, and it's kind of a cool perspective. So, before we close, is there anything that either one of you want to add to our talk?
I would just like to emphasize to my EMS colleagues to think about this issue. Think about what happens downstream when you bring the patient to the emergency department. You've got someone who you've called a stroke alert on. They've got that high blood pressure. If they're within that 4.5 hour window for eligibility for lytics, they're going to be giving them an antihypertensive agent so that they're complying with the AHA, ASA stroke guidelines anyway. So, consider using that out in the field. So it's a conversation to have with your
Medical
medical
director.
director. Yeah.
Yeah, that's exciting.
And I would just add, we live in exciting times.
Uh-huh.
The next 5 years or so, I think you're going to see a boom in pre-hospital studies for stroke, whether it's with the fancy ambulance or the blood test or not. I mean, we still have, most, if not a huge majority of folks unable to get that fancy ambulance or those tests. So we're going to have to figure it out on our own. Basically, how do we get these folks pressure down, and so many other amazing things. And I think this is where AI really can come into play as well. If AI can figure this out in some sort of amazing, calculus mathematical equation to let us know what is the rate that we should be using based on this patient's pressure and size of stroke or deficit. I mean, this is the next 5-10 years is just going to be, in my opinion, amazing with the research that's going to come out, and hopefully Mick and I will put a small dent into that ourselves.
Well, I hear you, and thank you both for being here. The only deal is that an AI pump that is an IV pump is probably going to cost more than $1,500. So I don't know about
You
that.
just attach it to your iPhone and you're done.
That works,
Yeah.
maybe. Yeah, that's awesome. Thank you both for being here.
Pleasure, Bram, and thanks for having us, and really enjoy your podcast. I've watched a couple of them. They're really terrific, and continue your great work.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover, but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplot from the International Prehospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for you to review on our website at iphmi.com. and also published through GEMS Online magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. Again, these are a great reference whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here. And they're all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials. Relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.